Hi, everyone. Good evening or good afternoon, wherever you're sitting. Thank you so much for joining us tonight for Ask Me, our educational webinar series. My name is Audra Hines, Vice President of Care Services for the ALS Network. I want to thank our lead accessibility and inclusivity sponsor, Mitsubishi Tanabe Pharma America, as well as our mission benefactor families and everyone who helps support our programming. The contributions from these individuals and families are really amazing, and programs like this one tonight, as well as the multitude of services we provide, would not be possible without these generous donations. November is National Family Caregivers Month. This month and every month, we pay tribute to the individuals who provide daily care and support to those living with the challenges of ALS. As a part of caring for your loved one and caring for yourself too, please know that we offer emotional support and counseling, short-term financial assistance for respite care to provide a much-needed break, as well as connection support groups and free access to the Waking Up app, all with the intention of providing help and support when you need it. The ALS Network is here for you. Please do reach out to us anytime if you need support. In addition, tied to the critical programs and services we provide, we work diligently from an advocacy perspective to support legislative priorities that are important to families living with ALS. Just to give a couple of current examples, the ALS Network supports efforts to establish a federal office of caregiver health that would ensure that caregivers are recognized as a distinct population with unique needs that are integrated into federal programs. One other important note is that in California, starting in January, a new law will allow family caregivers access to paid family leave without having to use vacation time first. This change provides greater flexibility for caregivers, enabling them to take up to 8 weeks of leave to support their loved ones without impacting their vacation days. To learn more about our advocacy efforts, please visit alsnetwork.org/advocacy. ALS is a complex disease to treat and manage, both from the perspective of the person diagnosed with the disease, as well as family members and caregivers. Managing emotions around the disease can feel difficult and at times impossible. Our speaker tonight will discuss this from the physician's perspective. Dr. Jeffrey Rosenfeld is a professor of neurology at Loma Linda University School of Medicine, as well as the director of the neuromuscular ALS and MND program at Loma Linda since June 2015. He established the Center for Restorative Neurology at Loma Linda, where he serves as the medical director. He has over 25 years of experience treating neuromuscular patients with extensive efforts in ALS. And he's also a member of our ALS Network's Scientific Advisory Committee and our annual ALS Research Summit Planning Committee. Dr. Rosenfeld, thank you so much for being here. We're really looking forward to this presentation.
Thank you very much, Audra. Just bear with me for one moment. I'm going to get myself settled here and share the screen, and hopefully that will work. Okay. Are you able to see my screen, hopefully?
Yeah, it looks great.
Okay, good. Well, thank you very much, Audra, and thank you for so many of you tuning in tonight, looking at the participant list. So many familiar names. It's like a clinic day for me, but I really do appreciate the time and effort and the invitation to be here. This is fun for me, and tonight is a little bit of a departure for me, and perhaps for yourself as well. Typically, when I give talks, and I've done similar before, I'm talking about the disease state, or perhaps a new therapy, a new medication, mechanisms of motor neuron disease and such. And tonight is going to be a little bit different, as you can tell from the title. Tonight is really a topic that comes more from experience, my experience, than it does, say, from the journals or science. But I'm going to try to pull this together. And the bottom line is, the focus tonight, instead of talking about specific mechanisms, medications, or those questions, which I'm sure you'll have at the end, this is going to be about how you perceive and the impact of how you perceive the disease has on the disease progression. And this comes largely from my experience, which I'm going to share with you, and hopefully share some of the patient experiences that I've come to understand. So I guess there's a couple of things. Why this topic? I'll tell you, in my tenure as a practicing neurologist, almost 30 years now, there is nothing as profound that I have seen as the effect of a way a person perceives their disease on how they progress with their disease. And I know that sounds kind of peculiar because you think the disease is the disease, but two people with very similar disabilities handling it quite differently, and the course is quite difficult. It is quite different. And I've seen this time and time again. Again, I'll share some stories when it's relevant. So this topic about the impact of your emotions, your perceptions of the disease progression really was the source of my curiosity on this topic. I'm going to talk a little bit about the science of ALS because it impacts why I think your emotions and attitudes might be actually affecting your disease course. And it has largely to do with the immune system. And your emotions and perceptions of the disease and the people you surround yourself with most certainly could impact your immune system. And the immune system has, we believe, a very important role in the pathogenesis of ALS and motor neuron disease. I'm going to show you some of the science behind that, although it is a little bit lacking in ALS. And then what can you do if you wanted to address things like your approach to the disease, your affect? We'll talk about that. So this is where we're going tonight, these 4 topics. And then, of course, I'll leave a lot of time for discussion and questions at the end. So a couple of takeaway messages. If I happen to lose you along the way, there are just a few things I really would like you to take away from this. Number one, ALS is a very treatable disease. Now, if that sounds unusual to you, if that statement doesn't seem like a natural statement to you, I'm sorry, it should. And it's not at this moment a curable disease, but it is a very treatable disease. And how we treat it is multifaceted. And we're going to talk some about that. But you should know that amongst the treatments that I believe make up a successful treatment paradigm has to do with paying attention to the person's emotion, to the patient and the caregiver and the family's emotional health and how they're processing the changes that they're seeing. As I've said now several times, your attitude and your emotions most definitely can affect your health. And I'm going to give you some justification for that in the science. Avoid fear, choose hope. We're going to talk about fear because I think underlying a lot of different types of anxiety, a lot of different types of ways to perceive your disease, fear is a very core and rather destructive emotion. And then my most favorite saying, I had to put it in as one of the takeaway messages. And if any of my clinic patients are watching and paying attention, you know, you've heard this. If you get your head in the right direction, your body will follow you. I believe this wholeheartedly, and I can tell you the converse is true as well. If your head is in the wrong place, your body will also follow you to the wrong place. So very important, and these are some of the main takeaway messages that I hope I can leave you with tonight. Let's talk about the field to begin with. For those of you who might not be aware, this is an intensely active area of research. Now, this slide is already dated because I think I did it at the end of 22, beginning of 23, and it shows how many papers have been published that are directly involved with some understanding of ALS. PubMed is a database where we all look for current literature, and it's usually maintained by the national, well, it's federally supported, and it's maintained by individual libraries, but you can search. And so if I search for ALS, 33,347 ALS papers. And if you just look in the 22-23 year, about 2,500 of them, just that year alone, divide by the number of days, every day there's new research advances. Now, I think this hugely progressive area of research advancement is interesting. And when I look at this escalation in the number of papers that have been published in ALS, I kind of see some inflection points, and perhaps you notice them as well by my line here. There are points in time where we seem to step up the activity a little bit. That's not an accident. There have been some seminal discoveries in the science of ALS that led to this accelerated production of publications in the respective years. Interestingly, all 3 of these inflections that I've indicated by the arrows relate to a discovery of a particular gene or a gene product and the respective years. And every time we saw a new gene that might explain some of the pathology of ALS, there was an explosion or new escalation of research activity. That's going to be very important as we talk about how this disease, how this understanding of the disease moves forward. But certainly I wanted to give you, before I talk about the main thrust of tonight, the emotions and your attitudes, I wanted to start by showing you some of the pace of research activity in the interest of understanding better the disease. So what are these papers reporting about? Well, this really could be the topic of a whole course, not just one seminar, but there are multiple mechanisms which are thought to give rise to motor neuron cell death. I've highlighted some of the main ones, took it from a nice illustration from a 2021 article, and each of these mechanisms of potential pathology or cell death has a lot of evidence. So you might even say, if given enough time, you could talk about any one of these, and at the end of a session or a talk, you'd say, oh, that's got to be the one, that's the one to go after. There are multiple ones that look like they're right. And more so than that, some of these mechanisms are interrelated. So for example, oxidative stress and glutamate excitotoxicity are very interrelated. Excitotoxicity and mitochondrial dysfunction might be interrelated. Neuroinflammation is a very popular current research trend that is a very focused area of research. So these are not necessarily mutually exclusive, but there are clearly multiple things that go wrong in a motor nerve cell before it degenerates. So sometimes, as I mentioned, there are markers to mark these interrelated. That's how we know one's related to the other. So when there's an inflammatory response in the nervous system, there are certain immune or inflammatory markers that you can see here. I don't know if you could see my mouse moving here, but TGF beta, inflammatory cytokines, very, very important, especially for our discussion tonight. And some of these earlier mechanisms here might help trigger the inflammatory response and collectively impact what's called messenger RNA dysregulation. I realize that's probably a foreign concept to many, but it has to do with how cells make protein. That's a very common mechanism of disease. And in ALS, it's thought that either from genetic dysregulation or from one of these other influences, the mechanism is disrupted. But particular to our conversation tonight, we're going to talk about the inflammatory and immune impact on the disease progression. Because studies like this, there was quite a bit more to this study, but studies like this show that if it's not triggering the decline of the motor cell, it's propagating the decline of the motor cell. So paying attention to inflammation, the immune system's response, very important. And please hold on to that thought, because that's going to be very important. So what most people who who receive this diagnosis, what most people see when they look on the internet is they see that there's a natural progression that is thought to be the disease course. In reality, this is not what we see in the clinic. What we see in the clinic is something like this, where people progress at various rates. This slide was borrowed from Erica Simpson at Methodist Hospital in Texas, but there are many slides like this which show a very large heterogeneity in the way the disease progresses. What is heterogeneity? Heterogeneity means that two people with the same diagnosis look very different. In this case, the rate of their progression can be very different. There's other areas of heterogeneity, but it is a curiosity. How can somebody with the same diagnosis as another patient have completely different presentation, a completely different course? Perhaps there are influences like the immune system, like inflammation, like perhaps genetic influences that impact this, and very worthwhile to understand, because if you understand why a patient with a very slow progression differs from a patient with a very rapid progression, we've done a lot to understand the disease. So this is another slide just highlighting, underscoring what I'm not talking about, which is how many different genes have been implicated in all of these different pathologies. So as we discover new genes, and many of those papers, those 33,000 papers that I showed you from the earlier slide, many of them are relevant to a particular mechanism of cell degeneration. But it's like a huge puzzle. It's like the most complex jigsaw puzzle ever in trying to figure out if the piece that you find that fits in, is it a central piece to the pathology, or is it fallout from another process? And that's pretty much what we're understanding. We clearly know that protein homeostasis is very important, as in abnormal RNA metabolism, very important. And these other mechanisms, oxidative stress, neuroinflammation, mitochondrial dysfunction, they do have a role. Trying to figure out if it's a primary or a secondary role and how to influence it, but it's clearly a role. This is a slide just to again show the extensive discovery on genes. Each one of these little alphabet soup things here are names of different genes, and the size of the circle that's relevant has to do with the impact of that gene. And of course, the year of discovery at the bottom. It's a very, very active area, and these multiple genes refer to multiple mechanisms. I'm going to pass over this because it's about the same. Now, if you move that heterogeneity to another area, it's not just the disease progression, it's how patients look. Do you have mostly wasting and weakness? Do you have mostly stiffness and spasm? Are you mostly having a bulbar, meaning speech, swallowing, and breathing problem? And all of this, all of these variants are all covered under the umbrella that we call ALS. Now, full disclosure, I'm biased. I actually think that there's important things to learn from differences between patients that look different. I am not convinced myself that everybody we call ALS has exactly the same disease. It's the same diagnosis because they have motor neuron degeneration, but do patients that look very different have different underlying pathophysiology? Not every one of my colleagues would agree with that, but I think until we know better, we have to keep open to that possibility. And we don't really know if, when we're cutting the pie, so to speak, and looking at how patients differ from one another, should we look at the patients with the bulbar involvement versus the limb, or the upper motor neuron versus the lower motor neuron extent, the fast versus slow, whether they have frontotemporal dementia signs or not, if it's localized or generalized, and so on. This is another area of active research, but when I think about heterogeneity, very much involved in understanding that heterogeneity is understanding how a person is dealing with their diagnosis. And that's what we're going to get into next. We have done, I don't have to tell this group, but innumerable clinical trials. This slide is already quite dated, as you can see, more than 15 years old. And it would just be the same. There are many, many trials and many, many failed trials in ALS. Now, why is that? Is it because we're measuring the drug's effect studying apples and oranges at the same time? Or is it another reason? Is it because we're not controlling for things like how a person perceives or deals with their disease course? Is it that we're not paying enough about their immune or inflammatory sense? There's a lot of speculation, again, a topic of a different discussion, but nonetheless, this is a humbling list, incomplete as it is. The other thing which is noteworthy while I'm on the slide is many instances we did the same trial multiple times. I can tell you, because I was involved in some of these trials, it wasn't because we were stupid. It was because we really thought it was going to work the next time because they changed something in the protocol. So there was a pretty good justification for many of these trials that didn't work. And they addressed multiple mechanisms. You can see the boxes are the types of mechanism that the individual trials. But relevant to this conversation tonight, I think often about why don't we have more robust clinical trial results? Is it that we just don't have the right drug? Is it that we're not paying attention to the heterogeneity of the disease and we should stratify the disease? Is it that we're not measuring the right thing in these trials? Or perhaps is it that we're not looking to see other influences like the one we're discussing tonight? So clinical heterogeneity, as well as the observation that we haven't really had a home run in ALS clinical trials is very relevant topic. So let's talk about you and talk about how you perceive the disease. So there are things that you know better than I do. You know that ALS results in an altered lifestyle. You know that there's ongoing disability, and that disability affects your life. I'm certain that I'm not telling you or your caregivers anything that you don't already know. That is a reality of the disease. When you get diagnosed, that is your first reality, because you're coming to terms with the changes that led to your presentation, and they have to do with loss of function. You also know that this disease came out of nowhere. Most people that get this disease actually nobody that gets this disease brought it on themselves. You were minding your own business, enjoying life, perhaps retirement, perhaps you were actively working, and this happened. This makes it very difficult to deal with. The disease occurred spontaneously, and you didn't have anything to do with necessarily bringing it about. You also learn early on that this is a lifelong condition, another reality that patients often come to the clinic with. And mostly, it's unpredictable. You don't know, and frequently we don't know what might happen next. So from an emotional state, if you look at what patients walk into a clinic with when they're first diagnosed, this 4 stages of reality, add them together, what is the most common, and as I mentioned earlier, debilitating consequence of these 4 realities? Well, I wish we were in the same room together, because I like to have a dialogue and hear what everybody thinks. But I'll tell you, it's fear. Everybody, almost to a person, whether it's expressed or not expressed, is afraid. For good reason. They're afraid of what comes next. They're afraid of how what comes next might impact the family, their work, their livelihood, and so on. I'm certain that I'm not telling you anything you don't already know, but what I can tell you is, of all of the disabilities that you have to deal with, in my experience of 30 years, of all the things that could go wrong in this disease, the most disabling thing that you will deal with is fear. The reason why fear is the most disabling thing is because it affects the way that you perceive everything else. Fear can be worse than shortness of breath. It can be worse than difficulty walking. It can be worse than difficulty functioning during the day, because your perception of the world and your condition is even markedly worse and much more disabled, because fear is a very unstable or irrational emotion. Well, if I'm telling you that fear is inevitable when you first get diagnosed, what is the treatment for fear? Well, again, in almost 30 years of practicing and treating innumerable patients with motor neuron disease, there's one thing, only one thing, that addresses fear, and that's hope. I know that sounds like just words to you, and this is usually when I would look in the audience and see you sort of maybe roll your eyes or so, but it's not hype. Hope is real. We're going to talk a lot about hope in just a few minutes, but hope is the antidote or the treatment for fear. Now, what is hope? What does that mean to be hopeful if you have this disease that you really don't want and you didn't see coming, and it's affecting everything about your being? What is there to be hopeful for? Well, hope has actually been a topic of research interest, and patient perceptions of hope have been described in the literature and quantitated, and there's certain patterns that. So hope for some has been defined as the possibility of a future that is better than an uncertain and difficult present. In other words, tomorrow will be better. You're not exactly sure why, but you have the notion that something will happen, the doctor will have another solution, the medicine will work, the family will fall into place, something will happen that tomorrow will be better. That's one definition of a patient's hope. Another would say that it's a strategy to help people cope, and coping and hope are very related, with difficulties to achieve their goals when faced with life-threatening disease. So hope is a strategy for some, a strategy to help you cope, and essentially the same thing, that you're finding a way to get by, to internalize it. If you don't have that mechanism to get by, what's the consequence of that? I'm going to talk about that. And then one of my patients once told me this, and it stuck with me for years. It was a young woman, and I always, as I lay out all the treatment options and the aggressive therapies that we want to embark on, and asking her which way she wanted to go. And what she typed out to me was, doing nothing is not an option. So I always say, you know, if you don't want to do this, we can wait. So doing nothing is not an option. That's her expression of hope. Now, in the psychological literature, it's a little bit more academic, but the notion is hope is a resource for patients from a psychologist perspective. It's a resource that influences and abilities and an individual's ability to cope with stressful, life-threatening situations. That's kind of an academic interpretation of what it is to be hopeful. And there have been a lot of studies published, not all in ALS, but a lot of studies looking at a hopeful perception and the impact on disease and quality of life. And here's one from 2011 that clearly showed that just the attitude of being hopeful improved the quality of life, completely independent of the disability. Now, coping and hope are very similar because, as I said, hope is a resource that helps you cope. And there are different kinds of coping that individuals would adopt. So in some sense, emotion-focused coping is sort of like, I got a gut feeling tomorrow is going to be better. And I think it's because this and this could happen, and I'm hoping for the best. Don't ask me the details. I got a gut feeling tomorrow is going to be better. Very adaptive. A lot of patients do this. And it's not really necessary to know why they're hopeful. And the other is a problem-focused coping, very analytical. Well, I did this, I changed this, so this should happen. If this doesn't happen, I'm going to do this. Totally also appropriate, not necessarily the same type of person that has this two strategies. But I had a very, I'm going to share this story about a patient that I treated many years ago. And he was quite a high functioning individual before he became ill. And he adopted many aggressive, proactive treatment techniques that I offered. And he adopted them. He did well with them. And he wasn't going to let this disease define him. So he, whatever it took, at in the later stages of his disease, he was in a power wheelchair. He didn't really have much use of any extremities, and he was on a ventilator. And this went on for quite some time. Well, there were ups and downs like everyone has, but he had a very aggressive, forward-thinking, almost ideal sense of possibility and hope. And I very well remember one day he came to the clinic and he was unusually happy. I mean, like euphoric almost. And it struck me. I mean, he was always a forward, active, pleasant guy, but this was like, really happy. And I said to him, "What's going on? You seem so happy. What's going on?" I thought it was something in the family. Well, he typed out, he knew I was going to ask him, so he had it ready on his speech device. And he typed out and he said, "I beat the disease. I don't have ALS." He said, "I don't have any ALS. I beat the disease." And I didn't get it right away. And I asked him more questions. And it turns out that he typed out and explained to me, he said, "I outlived the disease." He said, "This machine breathes for me. This machine helps me move. This machine," and he identified all of his adaptive equipment. And he identified and he says, "The disease can't take away anything else. I got it. I got everything covered. The disease can't take it away, and I won." It was many years ago when that happened. And that stuck with me because that was sort of the epitome, the best it could be to say he outlived the disease. It was fascinating, but he was a very, very problem-focused coping person. And he coped with the disease by taking it apart and realizing that he addressed every consequence and got an amazing sense of euphoria from this and lived many, many years with a pretty significant disability, in his case, believing that he had outlived the disease. So now there's been a lot of literature about this, about how your emotion impacts your disease course. A lot of the literature is in the area of myasthenia gravis. Now, myasthenia gravis is not ALS. It's not like ALS at all. It is not a degenerative condition. It is what we call an autoimmune condition. And an autoimmune condition means that the problem is the immune system. The consequence of the problem is the nervous system, the muscles and the nerves, but the problem is the immune system. Now, we think the immune system is involved in ALS, but nobody yet is saying that the primary trigger for ALS is the immune system. It's definitely involved, but a lot of the literature and understanding the impact of the immune system on the disease course has been in the area of myasthenia, where the immune system was the primary problem. So I'm using it only as an example, and in a moment we're going to come back to ALS. But in myasthenia, the body is making an antibody that is not appropriate. It's an incorrect antibody, and that antibody is causing the muscle and the nerve not to communicate with one another, and patients get weak, and they often have trouble swallowing and breathing and such like that. So there are many publications that underlie what the effect of attitude, emotion, and disease course are in myasthenia. This was a particularly interesting one because these folks, this was not about myasthenia, this was about mindfulness meditation. These were healthy people in this study. And they actually measured inflammatory markers and the impact of mindfulness meditation on the inflammatory markers. What grabbed my attention when I saw this paper, and it was actually dated, I think it's been more than 12 years old, 15 years old now, is that this marker, NF-kappa beta, C-reactive protein, and CD4 immunoreactivity, these are currently active lines of investigation in ALS. These are currently markers that we think are driving motor neuron decline. Perhaps secondary, perhaps primary, but these markers of inflammation are themselves dangerous, and they're decreased in production just by meditation, just by mindfulness. And cell-mediated immunity, which is different than the cytokine inflammatory response, those CD4 cells, which are protective in the immune system response, they are increased after mindfulness meditation. And as you can see, there's several other markers. Very interesting and ironically relevant, because even though it's been some time ago, we are currently looking at some of these markers right now as drivers of disease progression. This is a very busy table from the paper, and I'm only going to highlight some. You can see, again, I hope you can see my mouse, but you can see they measured a variety of different things in these various trials. But the bottom line was, when they found positive results, there was definitely a connection between the person's ability to meditate and be mindful and their inflammatory response. So your attitude, your emotion actually impacted the immune system. At the time they wrote this paper, of course, we didn't know as much about the immune system in some of these neurodegenerative conditions like ALS, but certainly it gives me reason to pause. And T cell, particularly T cell reactivity, T cells are a type of white blood cell and in your blood, and they're usually used to protect you. But in order to protect you, the way they do some of their damage and they kill things that shouldn't be there is they produce these chemicals called cytokines. And you can see the listing of cytokines here, IL-9, IL-22, and so on. And we believe that several of these cytokines are very relevant to motor neuron degeneration. Hold on to that thought, because cytokines, like I showed you in the mindfulness paper, are one of those areas that seem to be amenable to modification with your emotional state. So this is another paper, again, from the myasthenia literature, looking at the impact of hope and coping on quality of life. And I'll cut to the chase to tell you that the hopeful attitude was identified as significantly more important than the reported quality of life, which means to say that whether a person reports a questionnaire that their quality of life is good or bad, the hopefulness attitude had a much bigger impact on how they got along than it was what they reported on the questionnaire. And the other takeaway message from these myasthenia papers were the extent of disability, how disabled, how weak, how limited a person was, that had far less to do with the quality of life and the disease progression than the attitude and the ability to cope and feel hopeful about their situation. In fact, in this case, the quality of the myasthenic, quality of life in the myasthenic had much more to do with changing your caregiver, changing your job, or being depressed than it did have to do with your attitude. And this is really the takeaway message, that physical limitations were not the most significant factor. So if you're saying, well, I feel sad because I can't do what I want to do, it turns out that feeling sad can be quite independent of your loss of function. It might have been the trigger, but how you cope with that loss of function has much more to do with how the disease is going to progress than the actual loss of function. Like I said, you get your head in the right place, your body follows. So now let's switch back to ALS. There is an explosion of information about the role of the immune system in ALS, more than I can summarize in a brief discussion tonight. But I'll tell you that it's very relevant that some of the markers that look like they are playing a role are the very same markers that these papers and early literature identified as modifiable by things like meditation, hopefulness, coping strategies, and so on. This was a really interesting paper I came across. In fact, in preparing for tonight's comments, I came across this paper. And it had to do with, this is not about disease, it had to do with how inflammation is affected by your mood. And it showed that individuals who experience negative mood, that is, bad things happen and they caught them on a bad day, they studied them, they had, for several times a day, they tended to have higher levels of the inflammatory biomarkers in their blood than those who did not. Very interesting. Blood samples from patients that had had negative emotions such as sadness, anger, the inflammatory biomarkers were more present, but equally important was when they were exposed to positive mood before the blood sample was taken, they were lowered, the inflammatory markers lowered. Curiously, that last point was mostly true in men. I don't know why that is, but in their study anyway, men had a disproportionate benefit to the positive mood versus individuals. It's very provocative to think about the fact that something as simple, or perhaps sometimes not so simple, as how you perceive what's going on with you, how you deal with it, how you get your arms around it, or as they say, wrap your head around what's going on, actually impacts how you're going to progress with it. Again, this is actually a very recent paper. This is a company that's modifying, this is a drug NP001, which has been studied and unfortunately was a negative trial, but I believe it's being retuned up and we're going to see this drug again. This is an immunomodulating medication. It affects microglial cells, one of the key players of the immune response, inflammatory response in the nervous system, and how it's affecting on neurodegenerative disease. And so the impact on NP001, not necessarily dealing with emotion in this case, but certainly highlighting the impact of the immune system on motor neuron degeneration. I'm going to skip this because we're running a little low on time, but the point of this paper was in ALS, it was clear that people's perception of hope really varied. And again, if we were in the same room and I could have a dynamic discussion with you back and forth, I would probably get a dialogue going to show that not everybody hears what hope is the same. But an interesting paper, and I'm happy to share these references if anybody has an interest. Okay. Another paper that came out in the ALS literature showed that hope is a critical intervention. And interestingly, it wasn't just feeling hopeful about the disease, it was feeling hopeful about your caregivers and your treatment team. I thought that was really interesting. So patients that might have felt pretty bad about what's happening to them, if they felt pretty good about the care that they were getting and pretty confident about the caregivers that were providing it, including the doctors and therapists that were treating them, where they really liked the center, very therapeutic. We don't usually think of the clinic experience as being disease modifying. but I wonder if we should. I wonder if we should think about the benefit of actually receiving the care, impacting the emotional state, impacting the immune markers. I'm very fortunate here at Loma Linda because we have a very intensely multidisciplinary program. Many of you are familiar with it. Intense because all of the allied health folks, some of them are not even represented in these circles yet, they're all full-time here. So I have a full-time team, and they're fortunately very able to address questions and issues in between clinic visits because they're with me all the time, and patients have good access to them. So the reason we do that, relevant to the previous point, is to instill that sense of confidence that no matter what curveball comes down the road in the future, somebody in this team is going to know what to do. And if they don't, they're going to pool together because they're all working in the same area every day of the week, and we're going to come up with a solution. That kind of confidence comes from that kind of accessibility in a treatment team. There are other ways to be confident in your treatment team. It is just the way we do it here. I'm going to skip this again in the interest of time. So what can you do about this? Well, there's a lot of different ways to kind of bring yourself around to a better treatment, to a better place in your head. Perhaps it's discussion with the caregivers, perhaps it's a little introspection, and then there are some techniques, some different kinds of therapies. I don't know that there's one right way. I have seen patients who are quite spiritual become very much comfortable with the changes. Not that they like them, not that they wish for them, but they clearly do better with them because they are at peace. For some, it's not spirituality, it's meditation, it's yoga, sometimes it's acupuncture, sometimes it's actually therapy, supportive therapy, psychodynamic therapy, group therapy, sometimes it's support group, sometimes it's immersing in the family. It's different for everybody. But I do encourage you, if what I'm saying hits home in any way, I really do encourage you to find that spot for yourself. Find that sense of possibility, of purpose and hope, and hope for the best. There are different kinds of therapy. We have one, sometimes two psychotherapists, counselors that work with us and our patients, and they are involved frequently with cognitive behavioral therapy, but there's all different kinds that, again, discussion for another day, is not one way to get there. There's multiple ways to get there. You have to find what's right for you. So I want to wrap this up because I said I would stop at about 1:15, and I just want to again emphasize to you what I hope I've been able to show you, in that ALS is a very treatable disease. There's a large number of interventions that we do. Some of them are drug interventions, some of them are therapy interventions, some of them are equipment interventions. And then we have, of course, a number of clinical trials that we might get to talk about. Your attitude and your emotions can definitely affect your health. Even if I didn't show you the science, even if I didn't show you, and it's not very rigorous science, I admit, but even if I didn't show you the implication of the impact on the immune system, I can tell you from my experience, I have seen nothing more profound than the benefit of putting your head in the right place and having your body follow you. It is striking when I see somebody who gets it, somebody who starts out afraid and angry and upset and difficult and comes around and becomes actually quite well adjusted with the changes. The course of their disease is different. And I wish I could understand it better. And I wish I could tell you I knew what the marker was to look at, but I can tell you it's there. I've seen it many, many times. And again, I say, avoid the fear, choose hope, find what it is to be hopeful for you. Find what it is that brings you there. And actually, it's the same for the caregiver. If the caregiver is feeling hopeful, if the caregiver feels a sense of possibility and purpose, I do believe the patient senses that, and it makes definitely a difference. And then, lastly, as I say, my favorite expression, if your head is in the right direction, your body will follow you. So I want to stop there and hopefully didn't lose you along the way, and look forward to hearing any questions or points for discussion. Thank you.
This has been so terrific, Dr. Rosenfeld. I really can't thank you enough for doing this. I remember talking to you about this topic several months ago, and you had this great idea for doing this, and it's really impactful. It's pretty tremendous. It's a unique conversation for us too. And just for anyone, if you do have questions for Dr. Rosenfeld, just go ahead and type them into the Q&A function at the bottom of your screen, and we'll get to those. And I know you'll probably get some other questions tied to ALS and research and all kinds of stuff since you're here and we have you here. But I'd love to just ask you, you've been doing this work for so long, and was there one patient or was there one thing that led you to really start thinking about this piece of finding hope? I know, certainly other physicians and neurologists in the ALS space or not have thought about this, but you seem like you've taken it a step further and it's something that you really incorporate into your practice. I just wonder if there was something that really kicked that off for you.
Well, I think it was multiple things. It's a good question, but I've always been interested why patients look so different from each other. If it's a little different than, say, if you have congestive heart failure, for example. Not everybody looks the same, but you all have congestive heart failure. There are certain symptoms that you have, but you can have ALS and have a very different pattern of symptoms and the resulting a very different stage of disability. So I've always been intrigued by differences in the patients all throughout my whole career. And when I find a patient that I think is doing particularly well, despite the disability, I think about, in the past, I have thought a lot about that. I think, what is it? I mean, I have another patient that's not doing as well. They both have good caregivers. They're both from loving families. They're both, have resources. So I've ruled out things. And so over time, I've kind of evolved. And then there's stories like my patient that says I've cured ALS, or, I had a woman who I treated actually early on in my time here at Loma Linda, who has, at the time when I first met her, she had the diagnosis of ALS for 15 years. Wow. And I'm still seeing her. And that was, probably 8-10 years ago that I saw her. So in her case, it was a sense that they were members of the church, that it was a spiritual thing. And she really felt that she was covered, She had a peace with the fact that she was going to be fine. And she surprisingly is fine. I wish I understood that. That is intriguing to me, interesting story about that. And so I think it's evolved. And then when I hear about the advances in immune responses driving disease progression, and there's been an existing literature in myasthenia and other areas about the impact that we have on our immune system, adversely and productively, I think, why not? Why couldn't that be a factor here, contributing to the heterogeneity? Maybe that's something we should pay attention to.
That makes a lot of sense. We have one question that's tied to this for sure, asking, do acute and chronic ongoing vibes have similar effects? You talked a little bit earlier about kind of having a vibe about things, and I think that's tied to his question.
I'm not sure I understand that. When you say chronic vibes, of course I can't ask you, but if acute and chronic vibes, you mean like if you're feeling good, either chronically or just every once in a while, if you have a good attitude, is that what you mean?
Yeah, we'll see if he answers. I'm guessing it could be, on the positive or the negative side, I suppose.
Well, I suspect, of course, the direct answer is I don't know. I don't know if every once in a while having a good attitude is the same as having a good attitude and being hopeful all the time. I can tell you that the patients that really strike me are ones that are positive despite the adversity. So I don't want to, diminish what they're going through, because clearly they perceive changes in their condition. Clearly they articulate to me what they cannot do as well in the past. So it's not that they're indifferent to it. It is just that they don't allow it to define them, and they find a way to cope around it. And so I say to them, the best clinic day we have is when you come in and you're a little bit demanding in terms of like, okay, this happened. Now what are you going to do? I like that. It means that you're thinking of a solution. You're solution oriented. rather than coming in and saying, oh, geez, another thing happened. What's next? I want the team to be pushed.
Yeah.
I want them to say, I want the speech therapist to say, I got to come up with another way to use this device because this one's not working. And that sense of possibility is for many hopeful.
Mm-hmm.
And so whether I guess my bias would be it's better to be that way more times than not, because
Yeah.
if it's a roller coaster, perhaps you won't do as well, but it's never been studied.
Yeah, it's self-advocacy and taking charge of your care. I like what you said about that. It makes a lot of sense. Um, Someone else is asking, how do you know that the variation in disease progression is due to attitude and not the natural heterogeneity?
Yeah, I don't, but I can tell you what I think. I think when somebody is doing poorly, poorly as in they're upset all the time and they're angry and they're just, lamenting the next change that came, and I notice a change in their attitude and then they're doing well, I put it together. But to your point, what if they would have done well without a change in attitude? Well, we don't usually see that. I don't usually see that. I usually can see which way a person is going, but I wish I could tell you, specific stories, but in the interest of the confidentiality of the patients, I can tell you that some of our patients have become quite creative at the things that they come to clinic with to share by way of fun, it's not really pranking, but it's sort of fun back and forth dialogue. And before, when they weren't like that, they weren't doing as well. So it is a conclusion by association, not by proof in a scientific way. So it's a good question, but I just go from my experience.
It's hard to know. Yeah. Do you have, you talked about this a little bit earlier, Dr. Rosenfeld, but do you have patients who in the past or present who come in and really talk about, hope in their life or faith or whatever the mechanism may be, and really hearing it too from the patient perspective that, gosh, I feel like this is really something that's worked for me, that I'm tied to, right? That's really helping me cope with this disease. Do you hear that from them too?
Yes, absolutely. I mean, in full disclosure, I kind of bring it out because it's important to me to know where the patient is. So I oftentimes know what's going on in the family, if the person is working and what's going on there. And so we might start off by talking about, how was the wedding? How was the grandchild's wedding? Or how was something? So I bring it out to try to bring that. But one of the challenges is to figure out what it is that motivates an individual patient. And, I've also been intrigued. Another one of my curiosities and experience has been, why do people that are smart and well-informed, why do they make what I perceive as the wrong decision for treatment? In other words, they're offered an intervention to make a problem better, and they opt not to go for that. It's curious to me because, of course, you project. If you don't have, you'd say, if I was doing that, I would do everything I could. Well, I think a lot of it is the canvas that they're perceiving it on. If they perceive that as not helpful before they even know if it'll be helpful,
right,
it gives me a pretty good insight into where their thinking is. That would not be where I want their thinking to be. That provides us a chance on the team to try to redirect towards what I think to be a more appropriate or positive forward-thinking intervention.
And sort of tied to that, have you seen, piggybacking on what you just said, sort of for some patients, hope tied to a current treatment option, but do you also see some people hopeful around participating in a clinical trial, right? Yeah, potentially getting involved with something that's not approved necessarily, but it might work.
Absolutely. I think clinical trials can be therapeutic even when they're not successful clinical trials. And we all have had the case, and I'm not alone in this, that we'll do a clinical trial, the trial will be shown not to be effective, and individual patients will say, but I think it helped me.
Mm,
And to the extent possible, we try to keep them on the drug when the companies allow us to. But whether it helped them or the process of being in the trial helped them, we
sure.
don't know. But being involved in helping us understand the disease better. I have several trials right now where we're just taking samples from patients, even though they're not getting anything, but the samples help us, in my case, understand the differences between different presentations of the disease. And there's a lot of interest in volunteering for those trials, even though it's not going to necessarily make anybody feel better. So most certainly the idea, and I think that's my challenge. I have to keep
Sure.
trials coming in. I have to keep the options open in hopes of finding a something, and that's how I keep that's my role.
That makes a lot of sense. One more question, and again, if anyone has any questions, feel free to go ahead and submit those. What do you think about AI and the hope for technology and medicine advancement or the ability to diagnose earlier?
Well, I think it's exciting. It's very possible. Early diagnosis is a tricky business because what you're picking up on in early diagnosis are very subtle things. So in order for AI to be as good or better than I am at looking for subtle things, I think I would have to notice those subtle things to tell the AI what I'm seeing.
Yeah.
So I think we're not there yet. And I think the advances in AI are probably going to be elsewhere before they're diagnostic.
Mm-hmm.
But I think the whole field of AI is, in fact, you might find this funny, but again, preparing my comments for tonight, I was thinking this week, I wonder if anything's been published since I last looked at this, because I don't look every week. So I went to an AI tool and I typed in emotions in ALS and it actually gave me a little essay. It wasn't very relevant to what I wanted to talk about, but it gave me a little essay and it talked about the impact of the emotions on the immune system and things like that, but no details. But perhaps in the future, I would put down some of the research observations I'm seeing, and it would be a more powerful tool, but definitely on the horizon.
I love that. It's great. I think we are out of questions. Dr. Rosenfeld, thank you so much for this. This was a great topic. I think people got a lot out of this. I'm sure of that. Okay, wait a minute. Hold on. There's one more question. Someone says, I truly believe that a positive outlook is a treatment. Hobbies like working in the garden, even from your wheelchair, civic engagement, social gatherings, overcoming speech limitation is a concern. Should I explore methods for dealing with cognitive loss, or is it not a concern?
Well, that's hard to answer in generality because everybody's different. Clearly, there are a subset of patients that do deal with cognitive issues. Oftentimes, they're unaware of those cognitive issues. So the fact that when a patient asks me if they have cognitive issues, generally I think no, because they've got the site to ask me, but that's a little circular. I think I totally agree that those are important things, but that's on a case-by-case basis. It's hard to generalize, I would say.
Sure.
Yeah.
Do you know anything about infrared sauna for decreasing inflammation?
I don't. I know that there are a lot of sort of off the mainstream treatment modalities that potentially decrease inflammation. I'm sorry, I don't know enough about that particular one to say anything intelligent.
No problem. And I'll ask one of our staff on the back end. There actually is a website where you can check out some of these alternative therapies. I'll have somebody put that into the chat too. Yeah. I think we have a few closing slides. We're going to move.
I just want to say one more thing before you close, Audra. As I started, and I mentioned at the onset, this is a bit of an experiment, a little digression from me in my usual talk. Sure. I'm curious from any of those that are listening and participating, how this was perceived, positive or negative. And I honestly mean that, positive or negative, because I'm going to decide from this whether I should talk to other groups about this. And so if you have any thoughts about whether this was useful, not useful, what might be different, please share them. Is there a mechanism that they can provide feedback?
There is, and I'll actually mention that in a moment too. Everyone will get an email after this webinar tonight with a survey. Just answer a few questions, and Dr. Rosenfeld will be happy to share that with you too. Just some of the
Absolutely. And I'm open for negative or positive comments. So please.
I love it. I'm sure it's going to be all positive. No worries.
Okay.
Well, thank you. Thank you so much for joining us tonight, Dr. Rosenfeld. Thank you to our whole community. Honestly, we're grateful to each of you for your time and commitment and for being a part of our community. Once again, a big thanks to all of our sponsors for their support. If you have other questions that weren't answered tonight, including questions about what the ALS Network provides, please email us at askme@alsnetwork.org. The ALS Network brings our community together in various ways throughout the year to help create help and hope for families impacted by ALS today and for those who will be diagnosed in the future. These celebratory and meaningful gatherings provide opportunities for connection and to raise awareness and funds to benefit ALS Network's mission priorities. Please visit us at events.alsnetwork.org to learn how you can join us. And as you know, philanthropy fuels everything we do. We're so grateful to generous donors who make gifts of all sizes throughout the year, including contributions through an estate plan. To learn more about how you can support valuable programs like this one tonight, please visit our website at give.alsnetwork.org. And as I mentioned, please do watch for the short survey on tonight's presentation that you'll get just to give us feedback about all of our future programming. Thanks so much again, and we'll see you next time.